Hello, everyone, and welcome. You can hear me okay? Yes? Okay, perfect. Um, it's really an honor to be here with all of you today, and thank you all for joining us. Welcome to Chicago. I know some are locals, but some are coming from quite, other states and a distance here, California and the East Coast, as well in Jersey. So I welcome everybody, patients, families, providers, Cooley's Anemia Foundation and the staff, all providers, all healthcare providers, all industry partners who help us to really make a lot of progress in the field of thalassemia. The sponsors that Rolf already mentioned, Agios, Vertex, Genetics, Chiesi. And I feel like we really wouldn't have seen the progress that we have had today if we were not a strong community all together working toward the same goal, which is improving the lives and the quality of life of patients with thalassemia across their lifespan. In the next few days, we'll talk about different things that touch all our patients with thalassemia, from medications that are now available, oral medications, all the way to gene therapy, cure that we now achieve, and we have some patients who will be there in the room talking to many of you that have been for years, without a single transfusions. I would say it's a good problem for us to have, that now we have options to choose from. Before that, we really didn't have any. And I kind of almost vividly remember when we had the Cooley's Anemia meeting here in Chicago almost 4 years ago. And I remember my good friend and colleague, Dr. Thompson, was talking about gene therapy. And I remember around that time where the FDA kind of had unanimous approval for, the first gene therapy product. And I feel like, we continue to make progress, and that progress will never end. I think we will always move from one step to the other. So, and I'm very proud for all what we as a community were able to achieve for our patients and our families, again, really younger and older. Because we know that every treatment is not for everyone. And I think being able to come down to what, I like always to say, like the true shared decision making, where we know what is the best option for a given patient at the right moment, at the right time. I think that's really the beauty of medicine, where we can tailor the treatment plan, understand patient goals and where they want to be, what they aspire to do, what makes them happy at the end of the day, and facilitate that. That's our job as providers, increasing awareness and really making these significant changes for patients. And that will have to continue with more advocacy and better advocacy for patients, really, again, across different treatment options. And I would say the sky is the limit when it comes to thalassemia, and I think especially for some patients that maybe were not didn't have as many of treatment options before, like non-transfusion dependent thalassemia. Now we can actually offer them things, and today we'll talk a little bit about that in some details. But we all here will be available for other questions. But again, welcome to Chicago. Thank you all for being here. I'm really excited for a busy day with a lot of things we're going to learn. And please feel free to ask questions. We wanted this to be more collegial, more, also kind of social and casual connections, that we are here to help you and be part of the community. So thank you all for joining us today. Really appreciate it. I think we can go. Okay, perfect. So today we'll talk about extramedullary hematopoiesis, and as Craig referred to it as EMH, which is something we see in thalassemia, common and not common, meaning that some patient might have symptoms related to that, and we'll explain even what it is. But what you can see in the graph here, this is like a spine or a spinal cord for a patient, and you can see there are some arrows in the middle, and these are kind of more what we can call like tissue or material that kind of develop in the body in different places. And we'll talk about why it happened, where it happened, but I wanted to show you the picture to kind of really kind of make sure you understand even where we're gonna go. So these are extra things that shouldn't be there in the body that happen in response to anemia that can cause problems for us later on. We'll explain that in more details, but I wanted you to have that image that you can really maybe, we'll come back to it later as well. These are my disclosures, and I will leave it for a second. And then our objectives for today, we'll talk about thalassemia. I felt this is the first talk in the conference, so I have to do a little bit of like kind of background for thalassemia as well, a little bit about the complications, and then we'll kind of follow like a funnel effect, and then we go down to the EMH or the extramedullary hematopoiesis in particular. And we'll definitely cover both transfusion dependent and non-transfusion dependent. And then we'll talk about extramedullary hematopoiesis. How often do we see it? How patients present with that? What is the right way to diagnose? And how to manage and try to alleviate some of these symptoms when they happen. For me personally and professionally, I felt when I started my career 10 years ago, one of the challenges was always, I felt sometimes there is like a disconnect between when we see patients in the infusion center or transfusions or the clinic, we talk about different things and we go over medications. And I think we can all agree that dealing with a chronic illness is a challenge. It doesn't matter what it is. Is it thalassemia, it's sickle cell, cystic fibrosis. Chronic illness is a burden for patients, and it can get overwhelming with a lot of the problem and the complication develop over time and the things that you have to do. And then patients go home, and there can be other things that we are not aware of that comes in the way and kind of interfere with how patient actually will end up implementing that kind of treatment plan that we kind of talked about in clinic. And I put this out there because I feel like that inspired a lot of the work I did with like quality of life, patient-reported outcomes, adherence, but it also, want us to make sure, especially as providers in the room, to really take the time to understand how patients are doing at home, and some people know how I think about that, which is I don't take, like I'm okay for an answer. I really try to understand what patients can do, what they cannot do, what their actually daily activity look like. It is not just I'm doing okay, because we want to make sure we help them get to the best place that they want to actually be in rather than where they are right now. Unlock some of these possibilities that maybe they don't talk about or they don't think it's even possible, right? So I feel like quality of life is really kind of spot on in that kind of bridge. And I also want the patients and the families know that we think about the challenges that you have at home and you're not alone on that. And our job is really to support you, again, to really do the best you can and facilitate that as much as possible. So when we think about thalassemia and the complications, the pathophysiology, we all know it's like alpha or beta globin genes. So we classify thalassemia as alpha or beta thalassemia based on the genetic abnormality, as you all know, or where is the defective gene that is not working the way it's supposed to. That's on two different kinds of chromosomes that we all inherit from our parents. There's chromosome 16 for the alpha thalassemia and chromosome 11 for the beta thalassemia. And if there is really kind of any problem, deletion or mutation or any just defect in those, that can affect how much hemoglobin we can make. So I simplify it even to our residents and say, like, we all know thalassemia is more of a quantitative hemoglobin disorder or problem, meaning that you don't make enough hemoglobin, compared to maybe something like sickle cell, which is more of a qualitative. Like, you make hemoglobin, but it's not the right type of hemoglobin, so it's a different quality. When the babies are still, not born yet, we have a lot of hemoglobin we call hemoglobin F, or baby hemoglobin, fetal hemoglobin. That's on the left side of the graph, which is like two chains, as you see. There is like the alpha, the red, and then the blue, the gamma. But then the beta is the other one that kind of start making more and more of as the baby is kind of growing in the uterus. And then at the time of birth, we see that kind of hemoglobin switch that, kids or babies, instead of making that fetal hemoglobin or baby hemoglobin, start to make more of the adult hemoglobin that someone without thalassemia would have. So if there is any problem in making the alpha or the beta, there is what we call like the imbalance. And that imbalance, you make a lot of alpha, a lot of beta, that can cause a lot of problems, and we'll talk about that as well in a second. But that's really kind of the basis for thalassemia in different ways. And then, looking at what it looked like overall, this is on the left side, is like a picture for what we call a peripheral smear. So if we take a blood sample, look under the microscope, that's left side is a patient for thalassemia, the right side someone without thalassemia. And two things you're gonna see is one, how red the blood cells are. That means how much hemoglobin is in each cell. So if you have anemia, they're gonna be less red, in the blood cells. But then also you can see how crowded the red blood cells are closer to each other. So is there like a lot of white space in between? And that's also another reflection of the number of the red blood cells that are there. So if there is more white space, that means there is just more anemia. So these are the two things that you can appreciate in a very simple way between the two. But we know that problems happen in different ways and different things are involved in it. And as I said, it's really of the far left side, that alpha beta globin chain imbalance is really what starts everything. Because when that happens, it's what we call ineffective erythropoiesis, which basically the red blood cells in the marrow, which the bone marrow is really where we make all the blood cells, like kind of the factory. Really, the red blood cells struggle to come out of there, right? So that's what we call ineffective. It's just not effective. It's not working. And that leads to a cascade of things where either the red blood cells kind of break down sooner than they're supposed to, or even if they make it out of the factory, they also break down sooner. So they really kind of struggle and they may need help. And I think that's kind of part of the problem leading to anemia. And then we'll talk about iron a little bit, but there are other changes that happen. So, the bone is trying to work harder. So we see a lot of patients having bone problems because, again, the bone marrow is working so hard. We know the liver and the spleen start to get bigger a little bit because they are trying to compensate for that anemia, and we'll talk about it with the EMH, but then a number of other complications as well. And then iron overload, I feel like we can't talk about thalassemia without mentioning that how important it is to get rid of the iron, because it can be a significant problem for our patients with thalassemia. And we know that iron goes specifically to three big parts of the body: the liver, the heart, and then the endocrine glands. So that's like thyroid, parathyroid, pancreas. It's very important to try to get rid of iron as much as possible, that it doesn't affect these vulnerable organs. And I always love to think of thalassemia as a spectrum. So we have, transfusion dependent and non-transfusion dependent. And the difference is really how many times you need a transfusion in a year. And it's more of a functional definition, as we say. So if you need 8 or more in a year, that's transfusion dependent. If you need less than 8, that is more non-transfusion dependent. But there is a lot in between, right? So there are some people who might need 4, 5, 3, and that means that they're also going to be at risk for some of the complications. They may have pregnancy, infection, they may need more support at different times, and there are different kind of genotypes. But I always, remember that spectrum, because when you say transfusion or non-transfusion dependent, it feels as if it's like a 1 and 0, right? But there is really a gray area in between, so those patients can be at risk of complications if they are not well managed as well. And then, the iron overload is always kind of the elephant in the room, because it's unfortunately inevitable in thalassemia, whether it's because of the transfusion we give, and we say every 1 ml of blood gives a patient about 1 milligram of iron. So if you are a patient and you get like 2 units or 3 units, that's about 500, 700 milligram of iron. And that's way beyond our body capacity to handle that iron on its own. And that's why we need to kind of remove that iron away from the body so it doesn't damage the tissues. And anything we can do to decrease the need for that, I think definitely can be helpful to kind of slow down these complications. And that's just a simplified cartoon of how much the body can really handle, because with the transfusion, you get a lot already in. And also we know that the gut, the bowel, can absorb more iron in thalassemia, which also further contributing to the iron overload. So between getting the blood and the iron absorption, both of them become more, and more iron, unfortunately, that we have to deal with. And then, also again, a picture worth 1,000 words. So that's like a simple graph for a liver that was done by MRI, and I know a lot of the patients in the room, have done MRIs to look at the iron in the liver. But you can see that, this is someone who had a little bit of iron in the liver, but not too much. So you can see the color of the liver is kind of more whiter, kind of not super dark. But I'm sure you're going to appreciate this one when you compare them above each other. This is the top one. Someone has not that much iron, like really well chelated, which many of our patients are, and we're always very proud of how they're doing with that. But then if you look at the bottom, you can see how blackish, how dark the liver can look like for the imaging. And that's unfortunately when patients really have a lot of iron there. And that's why it's super important to really take that iron chelation medication as much as it is prescribed, because there is no other way around it. And in a similar way, that's another way to look at it with a different scan, a little bit of iron in the liver, but you can see how different it is when you have too much iron. And you can imagine that iron sitting there is not good in any way or shape. In a similar way in the heart, that's someone who had a little bit of iron in the heart, but not as much in the middle of it, between the ventricles, as we call it. But then you can appreciate when somebody have too much, that how it would look like with the red arrows. And why it would really matter, because we know that when patients have too much iron in the heart, that can increase risk of heart failure and other kind of complications, cardiac complications. And it is unfortunately our biggest challenge. And I have to say, and I say this out loud to some of my patients who, they make me nervous sometimes, because when I see their numbers are really going down to the point that it's really closer to that cliff. I mean, we talk about it as our team, and Hannah and Sarah here, and we kind of talk about our patient every week, and some of our patients, unfortunately, really just have challenges with chelation and adherence, and we know that it is not easy. But I think when I see that number start to go down, I worry about them, and I worry what could happen, and I feel like that's why it's always important to remember that there are things can happen if you go in that path. And that's another, when you look at the T2 star, a lot of the patient hear that number from us when we're looking at how much iron is in the heart, what we call it relaxation time, like how much the heart can actually contract on and off, as we all know. And if you have more iron, that number is going to be much lower, which will be kind of problematic and increase patient risk of heart failure. So let's shift gear and talk about extramedullary hematopoiesis, but I felt like guilty not talking about thalassemia background and iron overload in a talk of thalassemia in the beginning of a conference. So what is extramedullary hematopoiesis? It's basically producing red blood cells and other kind of blood cells outside the marrow. So the marrow is mainly in our chest, ribs, hips. That's kind of really where we make all the blood cells, normally. But then if the body is trying to compensate for that, and you're trying to compensate for that anemia, you have to start driving some of the other locations that maybe used to make blood cells when the baby was not born yet, right? And that's usually the liver, the spleen, some other tissues in the paraspinal areas, mediastinum. But that's kind of really what happened. It's a reaction and more kind of a compensatory mechanism to really the degree of anemia that patients might have. We see it more in thal intermedia or non-transfusion dependent compared to transfusion dependent patients, and I will kind of explain why as well. You can also see here in that image, that's like a CT scan you see on the kind of top view. That's the vertebrae in the middle, and you can see these kind of white areas on the both sides. That's on both sides of the spinal cord or the spines. And that's a common location that we see sometimes for patients because it can lead to problems, putting some pressure on the nerves. And again, we'll talk about that in a second. So why does it happen? So I mentioned in the beginning, right, thalassemia, patients have anemia because they don't make enough hemoglobin, right? So, and that all because of the alpha, beta imbalance, all of that lead to what we call, again, ineffective erythropoiesis. So the factory itself that is making the red blood cells is not working the way it's supposed to be, right? Either missing a piece, in the production line, or something is just not putting together, right? So you end up with a product that maybe not the way it's supposed to be, right? What does that lead to is it gives the body a signal that, okay, maybe we need to make more, kind of hemoglobin, But again, the factory doesn't have the necessary equipment to make it, right? So then you get what we call like EPO. It's kind of, it's a protein in the blood that drive more production of the red blood cells, thinking that maybe this will work, and it goes back, and again, the marrow is still not working because it's not able to make the red blood cells the way it's supposed to. So it ends up activating all the other sites that, at one point they were working before the baby is born, but now they're becoming or are getting more reactivated, right? Like they're getting back in action to try to compensate for that anemia. And maybe that's another cartoon kind of explaining it in a little bit like more details with like some locations as well. But it's really still the same principle, which is you have anemia because of the destruction of the red blood cells and they don't really live as long. You try to make more, in different locations, but also at the same time, it becomes like a vicious circle, right? Like, so anything we can do to kind of stop this process of anemia, perception of anemia, driving more, definitely can help to decrease the need for that. And that's why, for example, we see extramedullary hematopoiesis or EMH a lot more common among patients with non-transfusion dependent thalassemia, almost twice as much, because patients can live with like a lower hemoglobin. Like let's say 8, 9, we are hopefully now with like newer medications coming to the market, we try to change that and maybe have them achieve a higher hemoglobin level. But often they are around the 9 or 8, right? And that stimulates the body more to make more red blood cells, right? Compared to someone who is getting chronic transfusion and we are maintaining that hemoglobin above 10, 10 and a half, maybe 11 sometimes, you don't need, you are basically giving the body a break from needing to work that hard to get to that 10, right? So they don't need to work too much, and that's why we don't see as much of the EMH or the extramedullary hematopoiesis in those patients at all, or we see them but not as much. This is, if somebody have EMH and you took a biopsy or like a sample to try to look under the microscope, what kind of cells would you see? You actually would see all kinds of cells, even though the driver overall is really the hemoglobin, the low hemoglobin or the anemia. You will end up seeing all kinds of cells because that's become almost a replica of the actual bone marrow that makes all cells, because the body doesn't really differentiate. It just starts making all different kinds of cells. So you can see here in different cuts the platelets, the white blood cells, the red blood cells, the lymphocytes. So you can really see all kinds of blood cells here if you take a biopsy or take a sample of it. We see it a lot more common in males than females, and I'm not sure we fully understand. There are different hypotheses I wouldn't kind of get in details for, but we see it definitely a lot more common in males. It's almost 4-1 or 3-1, and some data out there says it's like 5-1, so it's more common in male than female. And as patients get older, we also see actually more of these kind of masses among patients with TDT and NTDT, but that's one of study that showed that the peak is actually more in the mid-30s and 40s, but I think it continues as well. And as I said, it's twice as much among the NTDT patients compared to the TDT patients, and there are some specific risk factors. So one of them is older patient. You get older, you can be at higher risk. If you have more severe ineffective erythropoiesis, which ties into the hemoglobin level, so we see it when patients have a hemoglobin less than 10, that's where they can be at higher risk of developing these extramedullary hematopoiesis or masses, which, if we can get them above, and we'll talk about treatment as well in a second, that actually can help us to kind of mitigate and decrease that risk of EMH or masses for those patients, whether TDT or NTDT. And then if they have lower fetal hemoglobin. Where do we see it? Spleen is a common one, and I think that's why a lot of the patients, especially the adult patients, would know that removing the spleen was a common thing that we used to do like maybe 20 years ago and before that, because one of the sites that would get activated, and then they start to have a bigger spleen, and that spleen start to chew on the red blood cells, making that transfusion needs are even higher. So sometimes we just have to remove the spleen to kind of mitigate that problem and do splenectomy. But it can also happen in the liver. The paraspinal masses are the common one that we see and can be quite symptomatic, and then in the mediastinum as well. So how do patients present? The good news is that mainly is actually asymptomatic, and many patients would not have any symptoms, and often we would see it as more incidental finding in an MRI. So we do MRI every year or every other year, it depends on the iron status. And usually we always would ask radiology to comment on the iron content in the liver and the heart, but also please check if there is any extra tissue or anything around the spine that we need to be aware of. And they give us measurements so we can evaluate over time how does that look like. So I would say that's common. It is really incidental, and the symptoms, as you can imagine, vary by location. So splenomegaly, abdominal fullness, back pain, chest discomfort, these are all symptoms related to the location itself. But the one that can be more complicated and more symptomatic is the paravertebral one that's around the spine on both sides. And we had a number of patients who experience either like low back pain, referred pain in the legs, sometimes wake them up in the middle of the night. And that's usually because those masses can be pressing on the nerves, right? So maybe a quick reminder that the spinal cord is there, and then between each vertebrae there are nerves that are coming out across all levels, right? So if you have a mass on either side that is there and it's not supposed to be there, it causes what we call like a mass effect. So it starts kind of pressing on some of those nerves one way or the other. And it can be all the way from just a little bit of tingling and numbness and a little bit of like pain, all the way to actual like bladder issues or bowel issues or other really kind of significant neurological problem that it can become an emergency that you need to act actually faster for. It definitely builds up over time, but you have to do something about it. You just can't leave it there. There are different ways to kind of diagnose EMH or extramedullary hematopoiesis. Of course, clinical exam is always key to really have an idea based on where it might be. MRI is the gold standard or the most commonly used and the best really technique to do it. CT have some risk of radiation, doesn't give you as much detail. You look for hemolysis, that's part of thalassemia. Some people, can say gold standard is really biopsy, but given the risk of, bleeding that can happen and morbidity, we do not recommend biopsy. So we really rely heavily on MRI for that. I put different pictures in a way that you can appreciate the variations in how we can look at it overall, right? So on the A section, you can see these are kind of on both sides of the spinal cord, as I mentioned earlier. The same for B, and then C, you can see a little bit of like in the closer to the liver area, and then in D, again, you can see similar to the image I showed in the beginning. These are really kind of big ones on both sides, and you can imagine how much nerve compression can be happening there. So that's why we really don't take these lightly at all. So what do you do about it? So transfusion is the first line of treatment, because if you remember, I said it's really the body reaction to that degree of anemia. So you need to get that hemoglobin above 10 to try to kind of decrease that desire the body has to compensate and build more red blood cells, right? So some patient might need to be on shorter courses of transfusion to get that hemoglobin above 10, and some do what we call like hypertransfusion to get them even higher, in a way that you are giving the body a message that, okay, you don't need to work as hard, I take care of this, you'll be fine, for the next whatever, until maybe that sizes start to shrink and start to kind of regress, because it definitely can help quite well. But we always know that transfusion comes with its own risk, right? You have to come to the hospital every 4 weeks. Now you have to deal with some iron overload that might happen. You may need some iron chelation, and there also the inconvenience of being there for the transfusions, of course. Hydroxyurea is a medication we use, and it can help to increase the baby hemoglobin and kind of decrease the need to make hemoglobin overall and kind of rebalance that ineffective erythropoiesis. We use it at a lower dose, and it can be effective, and we've used it for a few patients over the years with good response. You don't have to go like a higher dose like sickle cell, but it still can be effective. And then radiation would be another thing, which we don't really use as much because of the risk of radiation, of course. But for some of those patients that are really causing significant neurological risk, you may need to be more aggressive and you may need to use radiation. But at the same time, also there is risk of them coming back. So that's another reason why we don't use it. And then finally would be surgery, but again, that would be for more emergency situation if somebody has an actual neurological damage or risk that you need to just take care of it right away. And I would say, that's kind of based on the TIF guidelines. I can imagine like in another, kind of 5 years or so, when we have an updated guidelines, we might see some of the newer categories coming or already there, right? Like with the pyruvate kinase activator, like mitapivat, etavopivat, because these can also increase the hemoglobin level, get us to where we need to be, which is above 10. And maybe when we do that, we can actually decrease the risk of these EMH. But it's not in the guidelines yet, but I can foresee it, in 5 years, it might be there as well. And this is just like a schematic view especially for someone with like neurological. It kind of summarizes everything I talked about from the treatment option standpoint, but this is specifically for the neurological risk. And you can see if there is mild symptom, moderate, or severe. In the severe one, really you have to act fast to minimize the nerve damage, and this is where you may need to do surgery or radiation as well. But otherwise, transfusion, hydroxyurea are usually our first two options that we go by. So in conclusion, extramedullary hematopoiesis is seen in thalassemia, more common among the non-transfusion dependent thalassemia compared to transfusion dependent. It can have significant symptoms. Luckily, mainly it is asymptomatic, but if you have symptoms, the one that we worry about the most are the one related to the paraspinal area, because that can be significant morbidity. Location are liver, spleen, paraspinal, or paravertebral area. MRI is really the gold standard for diagnosis, and trying to get that hemoglobin above 10 is what we aspire for when we do simple transfusion or hypertransfusions. But you can also use hydroxyurea or low-dose radiation sometimes, and hydroxyurea alone can be effective. Low-dose radiation and surgery rarely needed, but they can be helpful as well. And I would like to thank all the patients and families that we are honored to take care of at our centers and referral from other sites as well. I would like to thank my colleagues and mentees and funding agency and the Cooley's Anemia Foundation for also supporting all the effort that we do at our center. So thank you all for your attention, and I'm happy to take questions. Thank you so much.
Thank you, Dr. Badawy. And we do have time for a few questions. Again, please raise your hand and a mic will be brought around to you. There's one over here.
Hey, I have two questions. Is the EMS research very new? Because I didn't hear about it, say, 5-10 years ago. And the second thing is, can EMH affect thalassemia minor patients whose hemoglobin is staying between 8 and 9?
Great question. Can you repeat the first one?
Yeah, the first one is EMH is this is the first conference I'm hearing about EMH. Is this a new thing that we are finding now, or was it always there?
Thanks for asking. So I would say it's definitely not new. I think it has been, I think as we are always learning better and better and understanding thalassemia, definitely has been around for a long time. I would say because most patients are asymptomatic, that's like 80-90% of the patients. So maybe it's not talked about a lot, like iron overload or other complications that patients might have over time, right? Like, or transfusion risk and other things. So it's not, new for sure, but when it happens in that 10-20% of patients, there can be significant morbidity, and that's why, if you don't think about it, you don't treat it, right? So you really have to be aware of it. So that's why I think it's important for us to always have that in mind. And that's why when we ask for the MRIs from our radiology colleagues, we always have to ask them, please kind of evaluate for these masses, because we know they can be there. And if they are going there looking only at the liver and the heart, they may not pay attention to maybe some other changes in the scan, right? So that's why it's important to be mindful of that. The second question about thalassemia minor, it's a really interesting one because I would say I don't think we know that what is the evidence or prevalence of EMH or extramedullary hematopoiesis among thalassemia trait patient. But what I would likely argue is I'm not sure if somebody had a hemoglobin of 8 is really have a trait or a minor. I think that patient likely may need a little bit more of like genotyping testing, genetic testing, because it's more likely that patient might have actually more NTDT or thal intermedia genotype profile and maybe was never tested because yes, you can be less than 10 with a trait, but it's usually like high 9s, mid 9s. You really shouldn't be all the way down to 8. And I always advocate if somebody all the way down to 8, 8.5 as a trait, I would likely need to get some genotyping for that patient to know that they are not actually an intermediate or an NTDT that being just like not managed and okay, you have a trait, you should be fine. Because again, now we have more options coming and maybe that patient want to do competitive sports, want to actually, have a different quality of life, like, hiking or whatever it is, right? And our job is to try to get them to where they need to be and where they want to be, right? So I'm happy to chat offline as well. And we have been fortunate to get most of the genotyping testing approved by insurance. So it really has not been an issue for us at all. Yes, please.
In the case, hello?
Where is the mic?
Right here. In the cases that you've seen, what % of thalassemia population requires radiotherapy or surgery in EMH cases?
I've never been at Lori for 10 years as a faculty and 3 years fellow. I have not used it a single time. I think we have been using hydroxyurea for the most part, and that has been enough. Max has like 1,000 milligram, which is like 2 capsules, occasionally 3, but not really more than that. Yeah, no need for radiation, but you need to know need to be aware of them, right, as a treatment options.
Thank you.
Of course.
Thank you, Dr. Badawy, for educating us about EMH. I just had 2 questions.
Sure.
One is because one of the clinical symptoms is back pain, which was on the slide, and that's something which even thalassemics who are transfused experience. So I guess it could be like, how do you know the difference between like EMH-related back pain and the others? That's number one. And then the second thing is, if you are a beta thalassemia major transfusion dependent and you are kept at 10 or over, is it still possible that you have EMH? What is the conclusive test to know that if you have EMH or not, and what do you do to treat it? Is it just that you increase your hemoglobin to more than 10? So I think I may have missed that part, but if you could just clarify that.
No, I appreciate it, Ralph, and these are really great questions, so thank you. I would say the first part, so you're right. Back pain can be non-specific, that you really don't know exactly what is the back pain coming from, right? So I would say it become more of like an investigation or a process of exclusion. Because to your point, we know that patients, because the bone marrow is working so hard and there is what we call like the bone remodeling or the cells that try to kind of keep the bone healthy can be affected if there is iron in the bone, right? So there is some risk of what we call osteopenia, so you don't have, the bone density can be low, there can be risk of osteoporosis, right? Or some patient might even have arthritis for other reasons. So there can be different things contributing to that back pain, right? So it's become an exclusion, meaning that you have to do the imaging to actually see if there is any evidence of a paraspinal tissue or anything around the vertebrae on the sides that is maybe contributing to that specific pain location. We see it more in the thoracic area, like in the chest kind of part of the spine. So if the pain is completely lower back pain, that can be unlikely, but you still have to do the MRI of the spine and ask them to evaluate if there is any evidence of masses there or not. So you really wouldn't know until you do the imaging to rule it out. And then if it is not there, and you know it when you see it, kind of, and if it is not there, then you have to evaluate for everything else, doing the DEXA scan, looking for other possibilities of that, why the back pain is happening, right? So you really have to do imaging to do that. And then, I'm trying to remember your second question was,
Yeah, what do you do to get rid of it?
the hemoglobin, yes. So it's kind of interesting you ask that too, because it's common when the patient have hemoglobin less than 10, but actually one of my first patients was an NTDT patient, and he had the spleen removed in Turkey. He was transfusion dependent for a while back there, but then he had his hemoglobin was actually, I think, closer even to 11. And he had EMH even on the scan. So we see the mass is almost like 2 by 3 by 2. And for someone who already have a hemoglobin of 11 and still have EMH, so it is, you still can see it, we wouldn't do transfusion for that patient. We did hydroxyurea, and he got better within 6 to 12 months, I would say. So you have to tailor the treatment based on, the hemoglobin level, the patient needs, and really what are you seeing on the scans as well.
Thank you. I'm sorry, I wish we had time for more questions, but we don't because we have to move on to our next presentation. So thank you very much, Dr. Badawy.